Mr. Chairman, dear colleagues, good morning everyone. Thank you very much for this kind invitation. It's a really great honor and pleasure for me to be here for many reasons. I think that it's important to have so big event in Kiev for us, for the APC, for all the Ukrainians that for many years work hard. They get APC, then unfortunately they couldn't organize, but we are sure, yesterday evening also we discussed with Natalia, will be very soon, also the APC here. And also for personal reason, I have many friends here, and this is for me a very charming and nice city, so I'm always very happy to be here. So can I have my first, yeah. Do you have a pointer as well? Yeah. So I hope I understood well, or actually I imagine I understood what Natalia told. Probably I will do my presentation one after the other, considering that I have an early flight during the afternoon. So I hope I will not make you sleeping because it will come a little bit of time. I will try to be short as much I can. So the first presentation basically is an introduction to the second presentation, which is focused on guideline for cystic tumor of the pancreas. And of course, I'm very grateful to speak about this argument, which is one of my, we can say, favorite topics. That doesn't work, I think. Okay, so just a brief introduction. Pancreatic cystic tumor are very frequent. It's high prevalence disease, 20–30% in the, we can say, higher prevalence studies. This is probably is something now very well known, but for me was surprising because when I studied medicine, I was not, 200 years ago, we considered this lesion very uncommon. Actually, they are very common, and we are becoming more and more common with the improvement of diagnostic tools that I use daily in our clinical practice. One of those lesions can progress from adenoma, so from benign lesion to cancer. So that's eventually very important because this probably is one of the biggest opportunities we have today to prevent pancreatic cancer, so to treat them before people develop cancer. But on the other hand, other of those lesions are benign, and we know that, so we never develop cancer, and the biggest problem is the accuracy we have today in order to make differential diagnosis between those lesions is very low. So by principle, we have a good instrument to make prevention of pancreatic cancer, but on the other hand, it's very difficult for us to understand what we are looking. Cystic tumor of the pancreas are a big variety of tumors. So this classification makes us really very nervous, but in fact, the most frequent lesion are, we can say, three, because solid subpapillary tumor are very easy to be recognized radiologically. The real problem is making between IPMNs, which represents the majority of cystic tumor of the pancreas, MCNs, mucinous cystic neoplasm, which is around 20% as well as a serous neoplasm. These three tumors, we can say, represent the majority of cystic tumor, and here we are playing our role in order to understand what to do with those patients. We start with IPMN. IPMN are a disease, as I told, that generally start with the low-grade dysplasia, so we can say adenoma, basically the same kind of model that we have for colonic cancer polyps, and progress through the years. Generally, it's told a 10-year period of time when the progression exists, to medium-grade dysplasia, high-grade dysplasia, and finally invasive cancer. When is invasive cancer? In particular, when lymph nodes are involved, basically this is pancreatic cancer. So we have no so big difference even in prognostic terms. IPMN can be classified by the morphology, so there are different morphology. When those lesions are involving only the peripheral duct of the pancreas, we speak about branch duct IPMN. Mixed type is an IPMN involving both peripheral ducts, so branch sides, and main pancreatic duct, and finally main duct IPMN are the one involving only the main pancreatic duct. Here you can see that branch duct IPMN can be unifocal, so single lesion, but most frequently they are multifocal and there are different lesions all around the gland, sometimes more focused in one part of the gland, less lesion in the other part. Main duct IPMN can be involving all the main pancreatic duct, like in this patient, sometimes in a very evident way. sometimes can involve just a small tract of the duct, and this is segment. And finally, mixed type APMN is a combination between main duct and branch duct. So both peripheral and main duct are involved. This classification, which is probably the easier one we have because we can see through the radiology, this is a classification was made in Verona many years ago by Procacci. Actually, it's very important clinically because clinically, main duct IPMN or mixed type, so when the main duct is involved, that means that the risk to have a cancer there is definitely higher when the branch duct are involved. And that's, as you can understand, make us very weird for this kind of lesion and much less for those kind of lesions. And this fact will influence, we will see, the guideline and the current management of those lesions. There are different histotypes of IPMN and different histotypes associated with different morphological attitude and also different malignancy transformation attitude. Now, what is important to see, and that's also is important to take in mind when we need to think about the management of IPMN, is that when we have a non-invasive IPMN, the survival is excellent. You need to take in account that this curve take also inside what was called before, now doesn't exist anymore, this classification, the borderline IPMN, what was IPMN B, and so there was even some, we can say, cancer in situ in this group, that today will not be anymore the case, but still, when you have not invasive carcinoma, the survival is excellent, but when you have invasive carcinoma, basically the survival is very poor. So that's the big problem. Should we operate all of them because if they become cancer, there is no chance or not? We will come back to this question a little bit later. Another interesting aspect is that probably location of the IPMN can play a role in the risk of transformation and malignancy. This study is a study from Memorial Sloan Kettering. I will not show you today, but I mean, we did a very similar study in terms of analyze the progression of IPMN, and we found surprisingly the same results. And what they saw here is that when the lesion is placed in the uncinatus, or for example in our data we saw in the head, the risk of malignancy, the risk of progression can be higher. Why is very difficult to say, but this is a fact that is registered first in 2013 by Memorial Sloan Kettering, and we found some similar data, I have to say. Another important issue when we speak about cystic lesion of the pancreas is that those lesions are frequently associated with risk for pancreatic cancer. So if you take a group of patients with a family history of pancreatic cancer, most of those patients has IPMN in the pancreas. So IPMN in some way, if you want, can be considered a phenotypic expression of familial pancreatic cancer. Here is the recent paper we published at Karolinska in our series of patients with familial pancreatic cancer. As you can see, at the moment of the screening, mostly of the patient that has positive finding, overall 40% of our patients positive finding at the screening, mostly of those patients has an IPMN. So IPMN is a precursor lesion of pancreatic cancer in general, but in particular is overexpressed in familial pancreatic cancer patients. So that's also very important, because till now we didn't know this information, and this information is important because IPMN are easy to be visible by radiology. So we have a group of patients at risk, and we have something that we can check and we can control. Here again, you can see that prominence and cystic lesion of the pancreas were the most frequent finding that we could see radiologically inside of the group of patients at risk for pancreatic cancer. The problem is how we deal with those patients, because when we analyze the data of the patient underwent surgery during the surveillance program for familial pancreatic cancer, you see that some of those patients has an IPMN, but the point is that most of them has intermediate grade dysplasia IPMN. So we did well to operate, or we did not well. Because who can tell us that this intermediate grade was progressing to cancer? And this is another crucial point we will discuss more in detail when we speak about guidelines. What we know, this is very interesting as well, this is an unpublished data we analyze now in our updated database, that in patients with familial pancreatic cancer, this is the risk progression of IPMNs. So they are the IPMN detected during the screening that go to progression. And this is the risk of cancer in those patients. As you can see, this IPMN risk progression is very similar to the one you have in the sporadic IPMN. I will show you in a while. But the risk of cancer is quite high. So there is the same rate of progression, but more incidence of cancer in familial pancreatic cancer patient. And this is clearly stated here. This is, the IPMN risk progression. This is a control group of sporadic IPMN. This is the familial. You can see it's basically the same. This is another interesting topic. We speak always about IPMN as a pre-malignant lesion. This is very untrue, in particular for main duct IPMN. We should take really seriously those patients, because those patients develop very frequently cancer. So those patients are really dangerous, serious. So I will talk you here, I have no answer for that, but about an argument which you can find anything in literature. What happens in patients with locally advanced IPMN cancer? Is it the same than pancreatic cancer? Is it not? Well, our philosophy is to treat them in the same way than pancreatic cancer. So that means, for example, that when you have a locally advanced, you do neoadjuvant treatment, but actually there are no data on that, and we doesn't know how to treat those patients. We should be more aggressive, less aggressive, difficult to say. This is something that I couldn't say locally advanced, at least for what is our attitude at Karolinska. This is main duct IPMN with the cancer in the head, so cancer IPMN with the infiltration of the portal vein, and this is a Whipple done with the portal vein resection and hand-to-hand anastomosis. You can see here the SMA and the hepatic artery. This is another case. Patient with malignified mixed type IPMN in the head with caval infiltration. And even here, vein infiltration is not considered by us contraindication for surgery, so surgery up front is what we are doing. Here probably it's not very easy to see, but anyway, this is just, the patient. We already did and divided, you can see probably here the SMA, so the artery first approach from a superior approach, left kidney vein, aorta, cava, and the tumor is attached by the caval vein. And here is the picture after the resection with caval resection, quite small caval resection, SMA skeletonized here, SMV, aorta, and left kidney vein. More difficult is when we have arterial involvement. So in this case, is what we generally do is the same approach we are doing in pancreatic cancer. This is a malignified IPMN of the pancreas. There was the first CT scan contact with the superior mesenteric artery without contact with SMV and without any other vessel. So location in the uncinnatus. You remember the slides I showed you before? Uncinnatus major risk for malignancy. Actually something we observed very infrequently, but still mostly of our IPMN cancer were in the uncinnatus. And you can see here, after neoadjuvant treatment, basically there was a shrinking of the primary lesion, but not of the contact with SMA. So our attitude in this case is to do en bloc resection of the vessel. Here we went to take the SMA in the root of mesentery, below the mesocolon, as you can see here, taking this control of the SMA on the origin from the aorta. This case has also a peculiarity because it has a right hepatic artery from SMA that fortunately was possible to save because was not involved by the tumor. And here you can see the dissection is completed, the tumor is just attached on the SMA from this small tract. So we proceed to cross-clamp the SMA and take it out the specimen with the SMA. You can see here the reconstruction with the hand-to-hand anastomosis of the superior mesenteric artery. This is even a more tricky case. This is a patient with a 3-vessel engagement. Same story quickly. So in IPMN, neoadjuvant treatment with FOLFIRINOX, partial response, but with the same engagement of the vessel. So here we took both SMV and SMA at the same level, root of mesentery below the mesocolon transversum. Here you can see, we can say from the left side of the patient, you can see here the aorta, you can see here the truncus, you can see here the SMA. So basically this patient had to reconstruct the hepatic artery, the SMA, and the portal vein. Generally, our preferred technique for the hepatic artery is to rebuild it through the splenic rotated, but in this case also the splenic artery was infiltrated. So basically what we did a hand-to-hand anastomosis on the SMA, hand-to-hand anastomosis on the superior mesenteric vein, and here we used the left gastric artery interposition graft. So by resuming what we know for IPMN, we can say that main duct or mixed type IPMN, as you saw before, associated with a high risk for cancer. For this reason, basically surgery is always recommended. And we will go in detail when we speak about guideline, which kind of surgery, when to do surgery. For branch duct IPMN, basically surveillance is what we need, which is not completely harmless. As you will see, surveillance means potential risk to skip cancer, but also a lot of money. So we need also to figure out how we can in the future handle that, but we will discuss a little bit more about that after. And surgery generally is recommended for patients with symptoms, solid component, maximum diameter of the cyst over 4 centimeters according with the European guideline, 3 centimeters according with the international guideline. We will discuss about that. Main pancreatic diameter more than 6 millimeters in European guideline, 10 in the international, rapid increase in size or elevated level of CA99. So I come now to another kind of tumor, MCN. Actually, MCN are basically tumor that happens in women, very rarely in men, and are typically single lesion. So if you see more than one cyst, it can't be an MCN. And generally, you have a solid component inside, in particular when they are big and malignified. You can have a cyst wall calcification. The median age is 50 years, so they're tumor of young people, and they can happen during pregnancy and having a rapid growth during pregnancy, because this tumor characteristic is to have ovarian stroma inside, so they are sensitive to the hormones. This is also a lesion that progressed from adenoma to invasive cancer. For this reason, surgery is always recommended. This is the typical example what happens with MCN, at least what happens in the past. This is a lady that in 2001 was treated with transgastric drainage for a pseudocyst in the pancreas. The problem is that the patient had never had pancreatitis, so it couldn't be a pseudocyst. But this is a small clinical information, simple clinical information, but many times missed. You see a young lady, you see a cyst in the pancreas, you say, well, what can be? Young lady, I mean, so it would be a pseudocyst tumor, is too young. The drain. 2012, invasive MCN, which was treated with distal plus stomach and vein resection. Here is basically another case. Exactly same history. Drainage in the stomach, that was done actually surgically, and then of course, appearance after 10 years again of symptoms, MCN cancer. And very funny that during surgery in this patient, they did a biopsy of the wall, was picking up for pseudocyst. Why? Easy. If you look here at the specimen, in the MCN, in particular when they are big, the pressure of the mucus inside making necrosis of the epithelium. So if you doesn't analyze all the wall, there are big chance it doesn't get tumoral cells. So you say, okay, is it pseudocyst? I have also histology. So biopsy on the wall, and in particular macrobiopsy, should never be done. This is an example of a very interesting case, young woman, pregnancy, abdominal pain, gynecological ultrasound saw first this big cystic lesion, CT scan, there was an MCN of the pancreas. We operate immediately after delivery. There are cases of people operated during delivery because this situation is associated with quite high risk of cancer. In this case, was not. Was a medium-grade dysplasia MCN. Again, take this lesion out before they become cancer is very important, because when they are benign, they can't recur, so patient doesn't need even follow-up, and they are cured. When you have cancer, independently by tumor wall invasion or not, still, you have not good prognosis. Surgery is always recommended, maybe with some exception. We will discuss more in detail about that. One important issue, I will come back on that, just take in mind, this is a recent paper we did inside to a very interesting group that I hope will be now joined soon even by Ukraine young doctor, Pancreas 2000. Actually, in this study, we did a review of literature, and we saw that when even IMCN, when they are less than 4 centimeters, the risk of malignancy is very low. So basically, it's true, they can progress to cancer. There are lesions that probably need during the life surgery, but when they are small, basically they are quite harmless, and probably they are much less dangerous than IPMN. Serous adenoma is the other cystic tumor, which is quite frequent, again, 20% in population. There are different kinds of serous adenoma. The more typical is microcystic serous adenoma. This is the most typical because, when you know radiology of those lesions, you can't make mistake. Typically, there is a central scar. It seems to be basically solid because the cyst has microcyst, so a very small cyst. So very easy to seems to be solid with this small cyst component and this central scar calcified that is easy to define at the CT scan. But when it's oligocystic, this is just a cyst in the pancreas, and that's basically it's impossible to discriminate between other lesions, like for example small MCN or branch duct IPMN. And finally, other confusing syndrome is the serous adenoma associated with von Hippel-Lindau, because if you see this picture, it seems very much like a multifocal branch duct IPMN. This condition is very rare, but still is important to know. And finally, serous adenocarcinoma, I personally doesn't believe exists. There are a few cases reported in literature. This is a study we did recently in GATT in the European Study Group on Cystic Tumor of the Pancreas. I go just briefly to tell you that the risk of malignancy in serous adenoma was considered very low, and we have big dubits if really those cases were correctly analyzed. And anyway, it's definitely inferior to surgery. So serous adenoma doesn't require surgery. Finally, the solid pseudopapillary neoplasm of the pancreas is completely unique tumor. It exists only in the pancreas, this kind of tumor, with large central necrosis. It can be in the pediatric age, excellent survival after resection, even of metastatic disease or locally advanced. All of them should be resected and patients should be followed. This is the appearance. Generally is a tumor with a capsule and a big extensive internal necrosis, as you can see from this picture. And basically, they should be treated surgically. So one very short mention to the differential diagnosis of a cystic tumor of the pancreas. We can say that what we suggest in the European guideline, and we will come back later on that, is the diagnosis could be done with MR, CT scan, endoscopic ultrasound plus or minus FNA, follow-up mostly with MR and AUS. This is also a difference with the international guideline. We doesn't want CT scan for follow-up for risk of radiation. New techniques could be pancreatoscopy, confocal light microscopy, or, in very limited cases, enucleation. Sometimes the diagnosis is very easy. As you can see in those cases, this is a typical serous adenoma, benign lesion in the head. This is a typical multifocal branch duct IPMN, and this is a typical main duct IPMN. But sometimes it could be very difficult. You can see these two tumors basically are the same, but the first one was a serous adenoma, the second one was mucinous adenoma. So this job is very tricky to make differential diagnosis of those lesions. This one, for example, small lesion in the processus sonsinatus. This patient has cystic endocrine tumor. This is a top PET positive, which of course could be possible to say maybe peripheral ring with contrast enhancement. But I mean, very, very dangerous to be skipped and say, okay, it was just a small cyst in the pancreas, nothing else. So this is an algorithm we made after the European guideline to say that in our opinion, endoscopic ultrasound really is not needed in many cases, just in few cases. When you have a clear diagnosis, as you saw in the first case I show you, basically you doesn't need to puncture a patient. Every invasive procedure has complication, and the accuracy is not even very high. The problem is when you have lesion that need surgery, in which the diagnosis is very complicated to be done. For example, more than 4 centimeters, and you decide to go to surgery if it's a mucinous lesion, but you doesn't do if it's a serous. Then probably endoscopic ultrasound could help to discriminate more. But endoscopic ultrasound has a low sensitivity. The cytology sensitivity is even lower. And this is an invasive procedure. It costs and is associated with risk, and very much is operator dependent. So we can't have the same quality everywhere. One important thing is that it's true, we made a lot of error. This is an analysis on our series. Overall accuracy of 60.9%, a little bit higher in the last period of the study. Endoscopic ultrasound doesn't add any accuracy in our diagnostic. But what is good, if when you see the clinical relevance of the error, this is only 85% of the cases. So there was a surgical series, means that 85% could have not surgery if we had the correct diagnosis for. All the other was just a matter of name of disease, but both of them could have surgery anyway. For the future, we have different tools we can use, like confocal laser microscopy, for example, or pancreatoscopy that maybe can help us to make our job better in terms of differential diagnosis. Sampling of the tumor can be indicated in very, very, very few cases. Cases in which maybe they are not very fit for surgery, you have a suspicion of a lesion, you try to reset, you make diagnosis at the same time, maybe treatment. I'm not really person very keen to enucleation of cystic pancreatic tumor. This is another case of a patient with familial cancer. We did a 3 enucleation of cystic lesion. One problem is the cost, we told already. So this is the approach we are doing now. So to follow those patients, imagine 20% of population under follow-up lifelong. It's a tremendously high cost. So what we did now, we did a study with 4 independent radiologists. We're analyzing the results of the full comprehensive MR protocol for the follow-up and a short 7 minutes SMART-SHIP protocol. And they concluded the accuracy of the full and the short protocol was the same. The study was done in 488 patients, and basically with the short protocol is possible to save 1.8 million of US dollar, which means a lot. So we need to go, I think, in the direction to improve accuracy, but at the same time to try to reduce risk, to reduce cost without reduction of accuracy in diagnosis. So in conclusion, we can say that pancreatic cystic neoplasm are a high prevalence disease, the highest of pancreatic disease. Some one of those, IPMN, mostly of them, and MCM, are precursor lesion of pancreatic cancer. For this reason, should be treated, but in particular should be followed and managed with care. Are a great opportunity for prevention, but at the same time are dangerous because we can also treat patients for a misdiagnosis that has not those lesions, and then they can have morbidity and mortality correlated to pancreatic surgery. The accuracy in diagnosis of pancreatic cyst is very low. And for this reason, I think that we need to invest in more accurate diagnostic methods and at the same time in less expensive diagnostic modalities. Thank you very much.
Thank you, Marco. Some questions, please.
Yeah, Marco. First, probably I missed, but I haven't seen the 16th group of lymph nodes on your photos. Did you take it out, or it was just a mistake?
No, we take it out, and I don't know in which moment the photo was taken. Generally, I use it to take it out, do lymphadenectomy and block. Actually, we changed the strategy because, I mean, it was very low accuracy in defining lymph nodes by pathologies if we took it out altogether. So, I mean, we generally do separately after resection. We complete the lymphadenectomy in order to have a... Yeah. Yeah.
Another question. If you deal with IPMS...
Yeah.
Can you please take the microphone?
Pardon. If you deal with IPMNs with an invasive cancer, then why do you resect, do upfront surgery in patients with invasion of vena cava as though they are all borderline and they need a neoadjuvant?
No, vena cava we consider like SMV. SMV we doesn't consider the borderline, we consider primary resectable. So vein invasion for us is primary resectable, artery invasion is borderline.
It's your local or you go according to...
No, it's not local. I mean, if you look even, I mean, the literature data and also different guidelines, they say that basically vein, it couldn't be considered exactly borderline, at least for small infiltration. For long infiltration, or if you have thrombosis, or if you have infiltration over under 80 degrees, that's the situation change, and then generally we do. We have a local classification of vein invasion at Karolinska. Basically, we define the one with more than 180 degree and long extension over 3 centimeters. We define grade B, and we define grade A2, the one with the less infiltration of the vein. So for grade B, we did upfront surgery. We analyzed our data. They were not going so well, so we started doing adjuvant before. For A2, which means less than 180 degree and less than 3 centimeters, then we do vein resection upfront.
Thank you.
Thank you. One more question.
Marco, thank you very much for a nice presentation. And my question about the case with arterial resection.
Yeah.
And this case was after a neoadjuvant treatment. And what were the pathology results?
Yeah, there was, this is interesting. Unfortunately, I have not the picture here. That was a positive infiltration of the very small group of cells. So what basically we saw, we also published a paper together with Caroline Verbeek. When you have neoadjuvant treatment, basically, the space occupied by the tumor doesn't change, but change the density of cells. So that's why even when we have a regression, we generally take it out the artery anyway, even if there is not any more radiological appearance of infiltration. The reason is that when you analyze the specimen, if the tumor was so big, you see not so dense tumor everywhere, but you see spots of cells still. So what you can have in after neoadjuvant treatment, you can reset the patient, you say, for example, SMA, you have a negative margin. That doesn't mean that it's negative, because maybe just 2 millimeter inside to the wall of the artery, there is another needle of another group of small cancer cells. So generally the extension doesn't change the density of the cells per millimeter. So this is why we are taking this approach. This is just an observational, so I have not 2000 data to say that it's like this. But that's what we observed in our series.
As for me, I think this is not a good explanation with the distribution of cells, because you have 1 cell or 2 cells instead of 10 cells. It means nothing for pancreatic cancer.
Exactly, that's exactly what I mean. So that's why we are extending based on the first CT scan. So basically what we plan the operation on the CT scan before neoadjuvant. We use neoadjuvant just a selection of patients that doesn't progress. That's basically the concept.
Very interesting. It's interesting. I hope to know it more about it.
Me either.
And the next question, we see quite a large difference between the recommendation for treatment of IPMNs with modified Sendai classification.
Yeah.
And why it is so?
I will show next presentations on the guidelines, so I will speak about that extensively.
Okay, thank you very much.
Thank you, Marco. No, last question. Professor Vygotsky.
Спасибо за прекрасную презентацию. Я так понял из вашего сообщения, что вы любите инокуляции. Инокуляции при отсутствии инвазии. И даже так понял, что речь идет даже о нейроэндокринных опухолях.
Yeah.
Были ли у вас рецидивы после инокуляции?
No, I have not, but I did very few. I have to say that I don't like enucleation. So I did very few cases for very particular situation. But, you know, I have a personal belief. If you do an enucleation, you should be basically convinced that you have a benign disease. If you have a benign disease, probably you doesn't need surgery. If you are not sure that it's a benign disease, then you couldn't do enucleation. So my idea is enucleation for neuroendocrine is another history. But I mean, for cystic lesion, enucleation is really limited in very, very few special cases. So I want to be sure I didn't get a wrong message. I don't think enucleation has a big role in surgery for pancreatic cystic lesion.
Thank you. Thank you.
Thank you, Marco. Next lecture for you.
Okay, now the second